In this segment, we're going to talk about the evidence, and welcome.
Thank you. Thank you so much, Keith. It's such a pleasure for me to be here. I've been enjoying the whole day since the morning, all these amazing lectures that you've been invited, and I feel very honored to be here. Definitely the spaces you're giving for education are very, very valuable because right now we're all facing this challenge that there's not enough research, there's more research needed, and the research that we already have needs to be well interpreted. And all this is circulating on the benefit of providing for the patient a safe medicine. So these spaces are incredibly important. I am an honorary professor of the Faculty of Medicine of University of Panama. I am in charge of the scientific and educational program, and I am also the president of the Colombian Medical Association, which I take a lot of pleasure because we are a group of doctors, specialists from different areas of medicine, psychiatrists, anesthesiologists, cardiologists. We're all looking for the same objective, that is promote education. So this is something very important, and I belong to different medical associations, and I think that through the medical associations is very important for our peers, for doctors, and for healthcare practitioners to find reliable information. So this is a little bit about me. I already told you what I do. This is a very common slide, but since I'm going to be talking about scientific evidence, it's good just to have a little bit of points, talking that we all have our own endocannabinoid system. All the mammals, we have endocannabinoid system, and since even we are in our mother's womb, we start developing endocannabinoid system. We have the natural produced in our body. That they were talking earlier, Dr. Onavi, about anandamide and 2-AG and another endocannabinoids. And we have different receptors that they have a specific targets for these endocannabinoids. We also have the phytocannabinoids. They are the ones that are coming from the plants. They are latest subject of a lot of research. Since we're going to be talking about evidence, it's very important. Why? When we are talking about evidence, and when I talk to colleagues and to policymakers and ministers of health, the first thing that I always get is we don't have enough scientific evidence. So we need to know there is different levels of evidence. And of course, sometimes we look for the gold standards. There are double-blind, randomized, placebo-controlled. There is different levels of evidence that I think that in medical cannabis, we will be evolving with the time. But it is a start. We start with preclinicals, and then we go to clinicals, phase 1, 2, 3, and on and on. And the important thing, and I liked what Jehan, Marco mentioned earlier, is there is a lot of our colleagues that they want to do research, that they have the tools, they have the patients, but they don't know how to do it. And they have even protocols that are already in place, but they don't know how to publish. So it's very important because we could have a lot of evidence that it could be ready to release, but not everybody is ready to jump into the water. So it's very important to have peer support and the support of entities that help others to produce research, like endocannabinoid medicine in the American Journal of Endocannabinoid Medicine. So these are very important initiatives for scientifics and for all of us. That what we want to see is medical cannabis to thrive and to be used in a very responsible and safe manner. And also with that, we will prove the governments and the policymakers that this is a safe medicine and that it's being done in the proper manner. Going to the core of my lecture, In the 2017, the National Academies of Science, Engineering, and Medicine, they did a very complete review. They reviewed around 20,000 articles about the health effects of cannabis and cannabinoids, and they selected what they thought there was the most reliable or better evidence in different pathologies. So we have in here, they found conclusive evidence the use of medical cannabis in chronic pain in adults as an antiemetic for treatment of nausea and vomit induced for chemotherapy and refractory epilepsy in pediatric populations, and improving spasticity symptoms in patients with multiple sclerosis. Also, they found moderate evidence and short-term sleep outcomes and sleep disturbances in patients with chronic pain, fibromyalgia. Also, they found limited evidence in anxiety, appetite, and gain weight, specifically in patients with ACE, PTSD, Tourette syndrome, and they said they didn't find enough evidence in treatment with addiction, neurodegenerative disorders, and irritable bowel syndrome disease, and also in cancer treatment. This was made in 2017, although in the last 3 years, some of new studies are coming out of the light. So we will be seeing these 4 squares moving, I think, in a positive way. I would like just to bring and give a little bit of date of the studies that they found, that they have more scientific evidence. I've been always very interested, in my main interest in since I started studying medical cannabis was epilepsy. So I'm going to go brief talking about this study. This study was made in Ljubljana in the Children's Hospital, and they use a sample of 60 patients, and they want to just demonstrate the safety and effectiveness of CBD as an adjunctive treatment for epilepsy. And what they found is with a dose of 8 milligrams per kilogram per day, 48% of these patients improved more than 50% of the seizures reduction. So this is a very important finding that we have in here, and very little adverse effects were shown in this study. They just shown some sleepiness and drowsiness, but most of the patients stayed at the study. We have in here another study, very good study that they were doing in Toronto at the Sick Children's Hospital, and they were using a combination CBD and THC. They were using a ratio 50-1 that is equivalent to CBD 100 milligrams per milliliter and THC 2 milligrams per milliliter. What they wanted to prove with this study is that this combination was safe and well tolerated, and also they wanted to see what were the outcomes that the patients have in quality of life, and see what was the changes the patients have in the electroencephalogram. So very important, they saw as side effects of adverse effects in patients that they were taking valproic acid. They had elevation of transaminases and the liver enzymes, and those patients that they were taking clobazam, they found elevation of the active metabolite of the clobazam, that is the N-desmethylclobazam. So they found that these patients were related more somnolence. So in here is a point to take that is very important, as they were talking earlier, interactions. Cannabis and CBD is a very noble molecule, but we need to watch all the interactions since it has a lot of different targets in our body. In this study, they were given to the patients from 2 to 16 milligrams per kilogram of CBD, and from 0.04 to 0.3 milligrams for THC. So they proved that it was very well tolerated. This is another study of epilepsy, very famous one. It was published in the New England Journal of Medicine, and it was with the isolate, cannabidiol isolate. It was a study, double-blind, randomized, controlled placebo. They treated 120 patients with cannabidiol, and they used the placebo, and they showed definitely the reduction up of the 50% in convulsions and seizures of the patients, different than what they saw with the patients that they were using the placebo. And again, the side effects, they were just vomiting, fatigue, and drowsiness, but they were no fatal or serious side effects that these patients were facing. So in here, I have a list of how many studies we have on epilepsy, and we have different populations. We have a placebo, controlled, randomized, double-blind, all the gold standards. So when somebody tells us there's no evidence, I tend to say maybe we want better evidence, but we do have some evidence and more in these specific pathologies. We have this study on multiple sclerosis, in the treatment of spasticity specifically, and they use a combination of Sativex, that is a 1-to-1 CBD THC ratio. Everybody knows it. And they did 5 randomized controlled trials in a total of 368 patients. And they showed that this combination definitely reduced neuropathic pain, spasticity, muscle spasms, and sleep disturbances. It's very important to note that in these patients, it's not just the pain. It's what it caused the lack of sleeping, the depression, the insomnia, and where medical cannabis help to improve the quality of life of these patients. I have a lot of studies in here, double-blind, randomized, placebo-controlled, crossover, gold standards of the studies. So we see, what I will say is maybe we need to see more what is the long-term effect. But do we have, maybe we will need bigger samples for these studies, but we have, as I said, double-blind, randomized, placebo-controlled that is actually good evidence. And we have scientific evidence also for the treatment of nausea and vomiting induced by chemotherapy. And in this study that it was made in 2010, so we have a lot of years building evidence. They show that the use of THC and CBD help these patients to control the effects of nausea and vomiting induced by chemotherapy. But what they were proving in this study is that they was used as an adjunctive therapy, not as a single therapy. So it's very important to know that it works better when it's in combination with the other antiemetics. We have data for a long time. We have in here a study from Calant in 2001. And since then, they were saying the cannabis remedies help patients with nausea and vomiting. We have this study with Cotter et al. In 2009 reporting the same. And now we go to the other part that is chronic pain. We divided in cancer-related pain and non-cancer-related pain. We have this study, a very good study. They treated 177 patients, and they gave them a combination of THC only, THC CBD versus placebo. And this study proved that the combination THC CBD, those patients achieved 30% of the pain relief, which is something very significant in this population of patients. This study was, again, multi-center, double-blind, randomized, placebo-controlled, all the gold standards that usually we look for studies. We have more studies in here with cancer-related pain. We have this in 2008 with a good sample of 2,970 patients, and they were showing how in the scale of pain, the patient decreased the scale of pain from 53% to 4%. And even in these patients, it's very important to assess the quality of living. And the patients reported the quality of living was 19%, and 6 months later, it was 69%. So very clear what is the role of medical cannabis in treatment with patients that has cancer-related pain. I have another study here done in Israel and showing precisely how the patients improved. This is the Canadian Pain Society guidelines, very interesting because they have the first line, gabapentinoids and other medications, tramadol, opioids, And cannabinoids used to be as fourth line agents. Now they move them from the fourth line to the third line. So that's an improvement. This is what we've been doing, building evidence and reviewing that the evidence we have is valid. We have other studies here with rheumatoid arthritis, 58 patients with placebo, Sativex, and we found, again, that the patients improve in movement, in pain, and sleep, and then no patients withdrew. Another study with Nabilon showing the Nabilon had a very good outcome for the patients. This is a study that is a systematic review that came out last week. A very interesting review. It was based on a systematic review for the using medical cannabis for the reduction of opioid dosage in the treatment of non-cancer chronic pain. So this is the latest review, and basically it took 7,200 participants, and they show that almost in 75% of these patients, they had a reduction of opioid dosage when they were combined with medical cannabis. But also they saw that when the patients were using medical cannabis in substitution of opioids, they reported benefits on the 59%. So we see that the combination with medical cannabis and opioids, they got better outcomes. Either way, the study says there's still more research needs to be done, but we can see here multiple systematic reviews, multiple double-blind placebo-controlled studies that they are showing us that definitely we have good evidence. Now talking about neuropathic pain, this is a famous study made by Dr. Mark Ware. They did with patients taking 9.4 THC inhaled, and they proved that the daily pain and sleep and anxiety of depression improve in these patients. In here we have, we know all the crisis of opioids in the United States, so we see that the pathologies the patients use more for medical cannabis for is pain, anxiety, back pain, and the list goes on and on. These are important facts, and I think all of you know them. The CDC on 2017 reported 47,000 deaths due to opioids. In cannabis and states, the medical cannabis is being legalized. They have less than 25% opioid deaths. Also, medical cannabis states have less prescriptions of opioids, which is really good. So we see here the effect of medical cannabis for reducing the consumption of opioids is really good. We have other studies in here proving how the reduction in consumption of opioids is being increasing every year because of the use of medical cannabis. In here, we see how patients prefer to use more medical cannabis instead of using non-opioids medications, so the rest of the painkillers. So we have statistics in here proving that it's not just for opioids, it's also for non-opioids medications that the patients are looking for medical cannabis. It was an observational study. They took 573 patients, and they showed that definitely the patients improve more with the consumption of the medical cannabis. Now we go to a part that is important to know because there is a lot of myths regarding to the effects in health. So we have in here cardiometabolic risk. What is the evidence we have that the medical cannabis or cannabis can cause in the heart? So we have in here limited evidence of statistic association between cannabis use and exposure with increased cardiometabolic risk, and demonstrated that has limited evidence in triggering acute myocardial infarction. This is the latest statement of the American Heart Association that was released last year, and they made like a very critical analysis of what is happening with the use of recreational cannabis and medical cannabis. And at the end, after all this study, they did a very thoroughly review of the effects of the medical cannabis and in the in the cardiovascular system. And they even did the study that they call cardiac study, that is coronary risk development in young adults. And they enrolled patients from 18 to 30 years and followed them for 25 years. And they showed that 48 of them reported history of cannabis use. But they found the cumulative lifetime and recent cannabis use did not show an association with incidence of cardiovascular disease, coronary disease, or cardiac mortality. The American Heart Association, they also in this study made a very important statement saying that it's very important to know that when a patient is going to undergo to a medical cannabis treatment, they has to consider, first of all, the follow-up with the patient and the doctors, because there is a lot of interactions of medical cannabis, CBD, THC, and the rest of the cannabinoids with different enzymes and with different medications. And even patients that have heart conditions, they have to be very careful, because we know the cannabis, specifically THC, can cause tachycardia, can cause in certain cases arrhythmias. And what they're doing in this statement was making a call to the clinicians and even to the policymakers and to the government to be very careful and aware that there is limitations right now in research, because there is not enough evidence in what are the real effects of medical cannabis and cardiovascular health, but it has to be treated with a very, very important evaluation of the doctors, because they've seen a lot of patients, and they said there is an increase of patients going to emergency room since there is the legalization of medical cannabis in some states. But they said that there is very hard to see if it was medical cannabis or recreational cannabis. And we need to know, and we know that recreational cannabis, they use very high amounts of THC. And in medical cannabis, the THC that the doctor prescribes to patients is balanced with CBD. And usually, according to the titration protocol that the doctor sees, you don't expect the patient to get intoxication or this type of side effects. Although interactions with medications, they have to be evaluated, but it's very important that they did this statement, because they see the increased number of patients using it. But we know that as a doctor, when a patient with unstable cardiac condition comes to the office, is a patient that you have to manage very, very, very carefully, and hopefully it can be managed in combination with the cardiologist, because it's a patient that it has to be treated very carefully. Then we have in here what they said about respiratory disease. They said that there's substantial evidence that the patients that they have smoking cannabis can have a bronchitis, episodes of bronchitis. Also, in immunity, we know that there is limited evidence of a statistical association between cannabis smoking and a decrease in the production of several inflammatory cytokines in healthy individuals. This with the COVID right now, there is a lot of research that they're doing, trying to demonstrate that actually cannabis could play a role in the decrease of the release of the cytokines. Time will tell. A lot of research is being done, and we will know what will be that role of CBD, particularly in this cytokine storm that is produced. We know that in this review, they proved that prenatal, perinatal, and neonatal exposure to cannabis, there is substantial evidence that the babies can have low birth weight. Also, it's not a mystery that when you are using cannabis, you have a higher risk of traffic accidents. And we know psychosocial effects. We have in here, there is limited evidence that these patients that use cannabis can have impaired academic achievements. We also have to be very careful, and we know this in mental health. The patients with family history of psychosis or schizophrenia have more predisposition to have the trigger of the psychotic outbreak. So it's not recommended to use medical cannabis, specifically THC, in patients with this mental health problem. It's the populations that they have risk of developing cannabis use usually are population of young people. That's what we try to avoid, that they start using it at an early age, and is one of the main things that us as doctors, we need to educate the population to tell them that is not, you can develop problematic use of cannabis when you use cannabis at very early age. So it says that there is moderate evidence that anxiety, personality disorders, and bipolar disorders are not risk factors for development of problem of cannabis use. And there is moderate evidence of the development of substance dependence or substance abuse disorders for substances including alcohol, tobacco, and other illicit drugs. Of course, the persons who are using other drugs, they have more predispositions to develop cannabis use disorder. And now here talking about the barriers in conducting cannabis research for finalizing my lecture will be regulatory barriers, including the classification as cannabis, of cannabis as Schedule 1. That is very hard for all of us to do research like that, and Dr. Sue Sisley was mentioned it. So it's very important, and I always ask the lawmakers, the politicians all over the world to try to find a way to allow doctors and scientists to do more research, because when we are not able to produce more evidence, it's very hard to treat patients, because we need to gain access to quantity and quality of the type of cannabis that we need to use for conducting different types of research. Of course, funding is needed, and we have to see the cannabis risk special populations we know in here, and patients with unstable cardiac or lung conditions, and children and adolescents. So in future, it's a lot of future for medical cannabis. I think we are just scratching the surface. I feel very optimistic, because in these moments where I see gatherings of doctors, specialists, scientists, engineers, all of them looking for answers. And I do think it's good to criticize something, but it's good also to be observative and to be responsible. And if encourage others to do research and help others to do research, not to block it, because that is the only way that we will get a better science. And at the end, what I say is we all do this because we want our patients to have proper medicine, well-regulated but safe, because this is what we need now, safe and standardized product. And my biggest flag is education. We need proper education. We need to disinformalize education, because right now I think it's very important to encourage universities to start teaching endocannabinoid system in the universities. I am professor of the Faculty of Medicine, and I feel very proud and happy to say the next week we will start with a program to teach endocannabinoid system to students of the first grades of medicine. So I just hope that these initiatives go all over the globe, because that way our doctors, since they are getting trained, they will be aware of what the endocannabinoid system, and I'm sure we will have a better science for the patients. And I leave you with this. Nothing in life should be feared, only understood. Now is the time to understand more, to fear less.
a great place to end. Thank you very much, Dr. Carrillo, and appreciate you joining from Panama and bringing your knowledge and especially the education you bring to medical professionals through the evidence that you just touched on. I know you just scratched the surface.